Welcome everybody to this really exciting British Heart Foundation Data Science Centre Research Showcase Day, packed full of excitement and cutting edge new data science research for you. My name's Cathie Sudlow. I'm Director of the British Heart Foundation Data Science Centre. You'll be hearing a bit from me at other stages throughout the day. So I'm going to very quickly be quiet and hand over first to Professor Sir Nilesh Samani, who's Director of the British Heart Foundation and has been supporting this initiative right from the very beginning several years ago. So Nilesh, over to you to provide the opening address.
Thank you, Cathie, and good morning, everybody. It's good to see so many of you here. As many of you know, the primary mission of the BHF is to save and improve lives by funding research to advance knowledge of cardiovascular diseases and its translation to patient benefit. To do this, we need appropriate access to an analysis of healthcare data towards realizing this mission. In this regard, the UK has substantial and unique strengths and assets with its single healthcare system and many valuable national registries. So it was with this ambition, i.e. to better harness the enormous potential of routinely collected healthcare data, that we established the BHF Data Science Centre just over 2 years ago. We consulted widely with many stakeholders, including data custodians, patients of the public, clinicians and researchers, to ensure that the principles under which we established the Data Science Centre were sound and supported by them. I know that many of you on this meeting were involved in this process, and I would like to take this opportunity to thank you for your contribution in shaping the Centre and its purpose. Some of the key principles that we thought were essential at the outset were, first and foremost, placing the patient at the heart of the centre by effectively engaging with patients and the public. Second, to make the centre UK-wide and institutionally agnostic. And hence, we are very delighted to partner up with HDI UK, and Andrew Morrice, who will be speaking after me, will say a few words about this. Third was to make the centre accessible to a wide range of users, not only researchers, but also policymakers and regulators, such as NICE and the NHS itself, who have a legitimate interest in advancing patient care. And finally, working with NHS bodies to develop a robust information governance process. But first, what we needed for the centre was an exceptional leader, and I'm truly delighted that Cathie Sudlow agreed to become the director. Neither Cathie nor anyone else amongst us would have anticipated that within a few weeks of her starting 2 years ago, we would be in the middle of the pandemic, and the initial work of the centre has rightly been shaped by the response to this. However, as you will hear today, there has been substantial progress on many fronts. The BHF are very proud of what the centre has already achieved. However, our ambition for the centre is unlimited and will really be guided by you as to how it can be maximally developed to advance our understanding of diagnosis and management of cardiovascular diseases. So I hope you enjoyed today. I know that there's a survey at the end of the meeting which you'll be asked to complete, but afterwards feel free to write either to Cathie or myself and tell us about additional opportunities that you think that the centre should be seizing. So I'll now pass on to Professor Andrew Morrice. Andrew.
Nilesh, thank you, and welcome everyone. Just to echo Nilesh's words, you'll be very pleased. I've got no slides, so I just want to say a few words about what I think is a fantastic event with over 500 people registered. I was invited to go to Cheltenham today, but I turned down the invitation because this is far more exciting. A steeplechase of cardiovascular research. And can I just say, it's a real privilege for Health Data Research UK to be working in partnership with Nilesh and the BHF team to do something that we think is going to transform research and care for people living with cardiovascular disease globally. So today we have an outstanding program. I just want to make three comments. Firstly, progress. As Nilesh says, the centre is very young. It's 805 days old, and 90% of its lifetime it's been living through a pandemic. Despite that, you'll see from today's program great exemplars of health data science at scale in cardiovascular disease. the thought of running studies on over 50 million people 2 years ago was unimaginable. We are now doing that routinely. But not only are we doing great science, we're helping, the BHF Data Science Centre is helping to shape enabling research infrastructure, which will be the benefit for all. So a real exemplar of team science. And I think that is absolutely fantastic, and the progress is exemplary. The second comment I would make is around opportunity, around impact. Specifically, what we saw in the pandemic is what I call a convergence of care and research, whereby if researchers were able to access near real-time data for research, then research findings very rapidly fed into policy making around vaccine safety, vaccine effectiveness, the identification of severe COVID susceptibility genes, which fed into adoption of therapies into the recovery trial. So what we saw during the pandemic was the real importance of research in terms of decision making at the system level, at the UK level, and at the global level. And as we come through the pandemic and address the pandemic of cardiovascular disease, I think there's an opportunity to continue this relevance of science, so that science and research is seen as an asset to society rather than a liability in terms of a draw on public finances. So the opportunity to use our research for direct, near real-time impact. And my third comment is, I think the centre is an exemplar of partnership. If our ambition is to transform science practice and healthcare for cardiovascular disease globally, it will require strong, trustworthy partnerships. Not one institution or sector can do this themselves. And I think that has been exemplified by the centre, particularly in partnership with NHS colleagues across the 4 nations in Northern Ireland, Wales, Scotland. But I would like to call out the partnership with NHS Digital, Fran Woodward and Michael Chapman, because we now have a trusted research environment which is accessible to all accredited researchers for over 55 million people living in England. So that's a major development. So thanks to the leadership of our NHS colleagues. But our partnership opportunities are endless. In HDR UK, we have strong alliances with the Turing Institute, ONS, NHS England, Research Data Scotland, ADR UK, the Geospatial Commission, and internationally with the Gates Foundation and other international bodies. So as the centre matures, we should think about data-driven innovation at scale that really galvanizes the focus that many of our partner organizations have on data driving societal benefit. I think it was Henry Ford who said, coming together is a beginning, staying together is progress, and working together is success. So it's a great pleasure to be working in partnership with you. Let's do great things for people living with or at risk of cardiovascular disease globally. So Cathie, back to you. A huge privilege to be here today, and thank you for all that you do.
Thank you very much, Andrew. Thanks to both Nilesh and yourself. The centre wouldn't be thriving as it is without your support, enthusiasm and encouragement. And thanks to all 500 or so of you who have registered and hopefully joined us this morning. Just to keep us all on our toes, there will be a few subtle changes to the programme as we go through to accommodate changes in availability and timing of various speakers, loss of vocal function and various other COVID and non-COVID related changes, but none of those are going to do anything other than add to the excitement and dynamism of the day. So it gives me great pleasure to introduce our first speaker, essentially the person who does all the work behind the scenes to keep the show on the road. and that is Dr. Lynn Morrice, who's Director of Operations for the Centre, who's going to introduce you to the Centre, our aims, vision, mission, and all the stuff that we do. Lynn, over to you.
Thanks very much, Cathie. And it's a pleasure to be here to provide an introduction to the BHF Data Science Centre this morning. So Nilesh and Andrew have set this up really nicely, actually, with the background to how this centre came into being. And so the BHF Data Science Centre was officially launched on the 1st of January 2020 when Cathie took up her post as director. We have funding from the BHF, an initial 10 million over 5 years, but expectation is that we will leverage additional funding on top of that. And we're really lucky to be embedded within HDR UK, so we can contribute towards and also benefit from the great collaborations, initiatives, and their UK-wide footprint, which is great for us. So our vision is to improve the UK's cardiovascular health, and doing this using large-scale data and advanced analytics. I'll just skip that one. And our aims are to develop national research capability and to facilitate UK-wide health data science research for cardiovascular disease at scale. And as Andrew mentioned, this needs to be done with trustworthy partnerships. So having that team science approach, being very collaborative, and acknowledging that we need lots of different skills, knowledge, and know-how in order to do this. We also want to promote the transparent and publicly acceptable use of health data in cardiovascular research. And we obviously work closely with patients and the public to do this, but also with the wider clinical and cardiovascular communities. And we do a lot of this in collaboration with HDR UK. We will use driver projects to develop and test the use of innovative approaches, and this will drive very much a lot of the work that comes out of the centre. And finally, we want to share what we've done, what works, what doesn't work. We have very much an open science ethos, and actually listen to others as well and learn from their experiences, and do this at a UK and international level. So this diagram, this schematic, which we call our Wheel of Fortune, is a representation of the BHF Data Science Centre and the work that it does. And I'm going to focus on those blue segments in the middle to start with. And those are our 6 thematic areas. So the first one is structured data, and this is health information that's captured in a structured or coded way, such as in your electronic health record. And we want to be able to better use and access this data that's collated at a national scale in order to do cardiovascular research. The next segment is unstructured data, and by this we're talking about things like information from images such as MRI or CT scans, but also information from free text, so when a doctor makes notes in your medical records. And very often this information is underused when it comes to research because it can be more difficult to analyse. So it's about making better access and use of this data, and also being able to link it to other types of health information so that we can understand better management and treatment of cardiovascular disease. The third segment is personal monitoring data. So this is collecting information from personal devices. So for example, your health app on your phone, or even a fitness watch, and being able to link this data to, again, other types of health data in order to actually understand how cardiovascular disease develops, but also to be able to manage an individual's particular condition more accurately. The fourth example is computable cardiovascular phenotypes, and this is about clearly defining different types of cardiovascular disease, such as, say, a particular stroke or a heart attack, in a format that a computer can read. And this will allow researchers and clinicians to be able to use better methods to analyse and interpret this complex information. The next thematic area is enhancing cohorts. And this is groups of people that have different types of cardiovascular disease. So we're very much interested, obviously, in these cardiovascular disease-based cohorts, being able to link this with other types of health information that we can then better understand the causes of cardiovascular disease, but also help us towards the prevention and the management and better treatment of individual conditions. And finally is data-enabled cardiovascular clinical trials. So it's understanding how we can use this health systems data that's collected as part of routine care and use that in the planning, the recruitment and the running of clinical trials to make them more cost effective and more efficient. This is all underpinned by 3 cross-cutting activities, and that blob in the middle is the coordination and engagement. And this is where the leadership, the project management, the health data support, the communications, patient-public involvement all sit, and it's the glue that makes it work. We have a talent and training, which is the grey arrow around the blue segments. And this is to actually develop the skills and knowledge and expertise to be able to do health data science research in cardiovascular disease, and actually nurture and develop those individuals. And finally, the driver projects, which I've already alluded to, that will drive a lot of the research and a lot of the work that comes out of the centre. And at the bottom, you will see something called the Diabetes Data Science Catalyst. This is a new partnership with Diabetes UK, and it will focus on diabetes and the links that it has with cardiovascular disease. So this is the team as it stands at the moment. So that big picture in the middle is when we all met in Edinburgh, which was great. I'm not going to go through everybody, and the reason I'm not going to do that is because you'll hear from a lot of these people today. They'll either be presenting or chairing sessions, but there are 4 people that I do want to highlight so that you won't meet. And that's Jackie and Reuven, who are at the front in that large photo. There are 2 research project managers, and they provide superb project management support across our thematic areas. Then there's Lydia Martin, who some of you might have come across. She is brilliant at organising all of us and making sure we know what we're doing. And finally, at the back, there's Debbie Ringham, who was our communications and engagement manager. She sadly left us to go and organise the Commonwealth Games, but just to say she was instrumental in the planning and organisation of this event. So big thank you to Debbie. And just to say that we are continuing to expand and recruit more members to the team. And this is just for our governance, and it's the current membership of our oversight committee. And obviously they oversee what we do, but they also provide a huge amount of support and advice, and it's really appreciated. And the name Kelvin Pitman you can see in the middle there is our public voice representative, and you'll be hearing from Kelvin next. So I just want to do a quick timeline of some of the highlights that have happened since the 2 years that the centre has been in existence. I'm not going to go through the pictures at the bottom. Those are when members of the team joined in the first year. And above the line is us getting our governance procedures in place. As Nilesh mentioned, this centre was set up, and then pretty quickly we moved into a pandemic, and obviously a lot of our work pivoted towards COVID-19. As part of that, a programme of work called CVD COVID UK was set up. So it's understanding the relationship between cardiovascular disease, that's the CVD, and COVID-19, and doing this across the whole of the UK, so at population scale. And this was given flagship status by the NIHR, which is the National Institute for Health Research, and the BHF, that have a cardiovascular disease partnership. And this led us to actually work in collaboration with colleagues within NHS Digital, as Andrew has already alluded to, in the setup of their trusted research environment in England. So this trusted research environment is a safe and secure environment where you can access linked data sources, different types of data sources that have been linked together and de-identified. And then accredited researchers can go in and access and analyse this data to answer specific research questions, and the data doesn't leave the environment. And you'll hear much more about this programme of work after the break. And also we set up our monthly webinar series, and we have a couple of speakers speak every month. Later in March, April time 2021, we had our first publication from the CVD COVID UK work that was in the British Medical Journal, the BMJ, and this was accompanied by an opinion piece from one of our public contributors. We also kick-started our personal monitoring data theme with a wearables workshop, and just below the line that you'll see that we recruited patient representatives for this, and this is just a reminder and to highlight the fact that we bring in patients and the public as we start to kick off the work that we're doing, to make sure that they're involved and they inform and advise on our work. And then just to show that Matt Sides, who was an Associate Director for Data-Enabled Trials, he started in May, and we kick-started our work on the Data-Enabled Trials theme by carrying out a survey with cardiovascular clinical trialists to understand their challenges of using routinely collected data in clinical trials. And he's got a session this afternoon, so you'll hear much more about that then. Then from middle of last year to present, again, we've had more people join the team, and you'll hear from some of them later today. The two people that you won't have seen before are the ones nearest the line, who are Camilla and Victory. They were two of our data science interns that was a programme set up through HDR UK that we joined, and it was great having them for about 6 to 10 weeks over the summer. Importantly, we met for the first time in person in July 2021, which was quite exciting. And we also ran a couple of workshops later that year. So one was with the cardiac surgery trials group, and that built on the survey work that we'd done earlier in the year. And then also we ran a imaging workshop, and this was to start the work within our unstructured data. And there is a session this afternoon that looks at imaging data. We released our wearables report, published our wearables report from the workshop. That was just at the end of the last year. And Tim Chico, who's the Associate Director leading that theme, will be speaking this afternoon to give you more details of what he's doing. And he'll be joined by Spiros Danaxis and Richard Sofat, who are working on computable phenotypes and the cohorts thematic areas. So you'll hear from all three this afternoon. And we've also kicked off a piece of work that crosses over two thematic areas, the data-enabled trials theme and also cardiovascular phenotypes, to look at outcomes for clinical trials. As I mentioned earlier, we're continuing to expand our team, particularly in the support around health data science and also in the communications and patient public involvement. And importantly, we're recruiting 3 posts at the moment, which you can see listed on the slide. So if you're interested, please do look at the HDR UK website and go to their jobs page. Just to quickly talk about the funding, so we've supported a large number of researchers as they're putting in grant funding applications, and so far we've supported successful grants totaling about just over £20 million. We've also funded, leveraged additional funding for the centre. This could be in actual additional money, but it could also be mainly in-kind costs where we've collaborated with others. And that's looking at about 1.5 million per year at the moment. And finally, just to highlight again the new partnership that we've got between the BHF, Diabetes UK, and HDR UK to form this diabetes data science catalyst that will sit within the BHF Data Science Centre. So finally from me, if after the end of today you want to find out even more about the centre, please go to our website and you'll be able to find links to the various reports that I've just talked about and other activities that are going on. Also go and check out our YouTube channel, so you'll be able to find particularly talks that we've recorded from our webinar series, so you'll be able to find out more about the work of the centre, but also some of the results that are coming out from the different projects that are going on. And that's me. Thank you.
Thank you very much, Lynn. A tour de force of all our activities to date, and I hope that whets people's appetites to hear more about unpacking some of those areas during the course of the day. But before that, and probably most importantly of all, the centre needs to be relevant to patients and members of the public who are, after all, the key beneficiaries of everything that we do and should be doing, and indeed work in partnership with us, as Lynn has outlined throughout many of our activities. I can't really think of anyone better to give their perspective on this than Kelvin Pitman, and we're extremely grateful to Kelvin for his support throughout the Data Science Centre's journey from very close to the beginning and over the last couple of years, both as a patient and as a friend and a professional. And as Lynn's outlined to us already, the lay representative on our oversight committee. So it gives me great pleasure to introduce Kelvin Pitman to tell us about a patient's perspective on the Data Science Centre. Kelvin.
Thank you. I don't know, my slides are coming up. Oh well. Anyway, I just want to introduce myself a little bit more in detail. Thank you very much, Cathie, for that, and also Lynn. I'm Kelvin Pitman, as you've already heard, and I'm here to offer you just a little bit of insight from the patient perspective. I've always been reasonably fit, but had a major heart attack 15 years ago, and was rushed to hospital by air ambulance and had a stent fitted almost immediately. About 5 years later, I developed an atrial fibrillation that eventually developed into chronic AF, and hence I have a little guardian angel, a pacemaker defibrillator implant. The fact that my dad was one of the, just let me see if I can move this on a bit. There we are, sorry. The fact that my dad was one of the very first to have an aortic valve inserted back in 1966, and being a patient myself certainly opened my eyes, and hence over the last 10 years I've been very privileged to serve on several British Heart Foundation committees where data has often been a key factor. This includes the British Heart Foundation Data Science Centre Oversight Committee, where I try and ensure that patients' perspective is kept in focus. Okay, data. You will often find that if you talk to a layperson just off the street about health data, or in the pub or wherever, their eyes will glaze over. And if you talk about patient data, they may start to glaze over just a little bit less. However, once you've been a patient with a chronic illness, you start to take a lot more interest and start to realize just how important it is. I hope in recent months COVID has opened the public's eyes much more to the importance of data. As clinicians and scientists, you will be used to treating data in a logical way. However, it's important to appreciate the public often have a more emotional response to their health data. Since I have a science background, I hope I understand both sides of this particular coin. Let me give you a personal example. My pacemaker stores data about my heart and wirelessly transmits it to a device by my bed that you can see in the picture there. Every so often the device downloads that information to the hospital. A couple of weeks after I got this device and everything was set up, I got a telephone call from a cardio nurse asking me what I'd been doing the previous Wednesday. Apparently my heart rate had suddenly gone through the roof. I had two interesting reactions to this. On an emotional level, I felt my privacy, my private life had been violated. What business did she have of being aware of what I was doing? After it was my heart, and what I was up to was only my business. On further thought, and at a more rational level, I was pleased and reassured that I was being well looked after. If something was going to go wrong, the hospital hopefully could warn me in advance and intervene. Just in case you're wondering, I think my heart rate was elevated because I was excited about driving 60 miles home in a 40-year-old classic MG I had just bought at an auction, and was quite anxious and a little bit worried about getting it home safely. It's a long time since I'd driven a car where you had a manual gearbox and stiff brakes and all the other things, so it was quite a challenge. Oops, get my pages sorted. Just to expand a little bit more on the theme, not the car, but the theme we're talking about, I was at a data workshop a few years ago when a GP, Dr. Mark Davis, who had been studying patient reactions, used an iceberg as an analogy. He said, when it comes to our own personal medical data, our response is like an iceberg. 1/10 logical, above water, 9/10 emotional, hidden below the water. This is why taking a patient's perspective on board is so important, even if it does not seem logical. Back in 2013, the Care Data Scheme was launched, only to be axed in 2016 because of massive public backlash, largely due to poor communication and a strong emotional reaction. Many of you may find it frustrating that you often have to jump over many fences in order to access patient data that is in the main bulked up and anonymized in order to protect individuals' privacy. However, please remember that the patients don't always see it that way. Of course, the British Heart Foundation Data Science Centre and the Health Data Research UK are here to help you ease your access to the data while also protecting privacy. Turning to more practical side of collecting patient data, in treatment and clinical trials, patients are often enlisted, help is enlisted. I've been present when many late-running or failing trials have been reviewed. In the majority of cases, it was due to slow recruitment and/or significant dropouts, usually because patients were being asked to do things that were difficult or not sustainable. I can illustrate this with an amusing but rather frustrating episode where my wife had a throat infection during COVID and hence an e-consultation with our GP. The doctor wanted to see a photo of the back of her throat. Imagine trying to say "ah" with a mobile phone stuck into your throat as far as possible, let alone get the light and the focus right. We couldn't stop giggling either because it just seemed so hilarious. Eventually we managed and my wife got appropriate treatment. I mention this story to highlight some of the physical challenges patients are asked to undertake, not only for treatment, but also for trials. As another illustration, much of my career has been involved in packaging research and development. As a training exercise, we were asked to put on gloves, oven gloves, and wear misted glasses, while trying to open several common forms of food and pharmaceutical packaging. The idea was to help us understand what it was like to have failing eyesight and be arthritic. A bit of fun as we watched each other's attempts, but a very serious lesson was learnt. So this is where I plea for patients to be involved from the very beginning and the planning of trials all the way through to the final reporting and presentation, because this will ensure you get a patient's perspective on both the emotional and the practical side of moving forward. Finally, despite the concerns about the device by my bed feeding my personal data to the hospital, it did prove very useful a couple of years ago in an unexpected way. My family wanted to give me a special treat for my 70th birthday, but I had to get a letter from my cardiologist to say that I was fit enough to do it. A quick look at all the stored personal data showed my condition was stable and gave my cardiologist the evidence they needed to write that letter. Hence, this photo shows me flying in a World War II dual-controlled Spitfire. And as you might notice, the ground is above my head, so I'm in the middle of a loop-the-loop here. And finally, a picture of the aeroplane itself. Many thanks for listening, and I hope you enjoy the rest of the day.
Thank you very much indeed, Kelvin, and thank you for sharing with us some particularly high-octane experiences. I was feeling quite nervous here. Now, I understand there have been a few problems with the visibility for those of you who are joining through the audience attendees link. Just to reassure you that those are being fixed, so bear with us. And please do stay, particularly for our next speaker who's giving a keynote speech. And I would just encourage you also to please do submit any questions that you might have for our next speaker using the Q&A function provided. So to introduce our next speaker, I'm going to hand back over to Nilesh.
Thank you very much, Cathie. It's an enormous pleasure to introduce Dr. Doug Gurr to give a keynote lecture today, not only because he's my ultimate boss at the BHF, but because he's a true champion of data science in health. Indeed, he's been a key driving force behind our ambition to create the BHF Data Science Center. As befits his interest, Doug did his PhD in computer science and was a postdoc in Aarhus in computer science and maths. For 9+ years, until he stepped down last year, he's been a senior executive in Amazon, initially running their operations in China and more recently in the UK. His day job now is director of the National History Museum. As I alluded to earlier, he's currently chair of the board of trustees of the BHF. He sits as a non-executive director on the board of the Department of Health and Social Care and also on the board of UK Biobank. Doug, we are very pleased that you've been able to join us today and look forward to your lecture. I know that you wish to have some questions at the end, and I will look forward to having a discussion with you. Over to you, Doug.
There you go, epic fail. Somebody who's supposed to understand technology and can't even find this new thing. Anyway, listen, good morning. It's an absolute pleasure to be with you this morning. And thank you, Nilesh, for that very generous introduction. As Nilesh said, I wear sort of two hats here. I know a little bit about health through the BHF, Biobank and the department. And, you know, I'm kind of a data geek and have been. So that's hopefully where this comes together. And that's why it's so exciting to have the opportunity to join this day. So if it's okay, I thought I'd talk a little bit about data. Maybe a little bit about health and data, a little bit about cardiovascular, maybe a little bit about what we learned in the pandemic, and then maybe what we should be thinking about doing next. And I'll try and keep this to about 15 minutes so we've got time to pick up questions. So please do use the function, type the questions in. If you don't ask any, I'm sure Nilesh will ask me some difficult questions. So for my sake, please come up with some reasonable questions rather than ones I know Nilesh will throw at me. But anyway, a little bit about data. And I can remember, if we go back a long time when I was doing academic research in this area, I remember this is 25 years ago, and I was part of an experiment where we were trying to teach machines to understand human speech. And the approach then was that you took words and then you broke them down into phonemes, the subsets of words, and then subphonemes. And we tried to break it down into the smallest possible component and then do a sort of a big, if this, then that, build it back up together again. So that was the kind of approach 25 years ago. And it completely failed. It failed to the point where we realized that it was actually impossible to understand human speech just based on trying to reconstruct each word or subword. You actually needed the whole sentence. You also needed to understand the body language. What am I saying? What am I doing with my hands and all of this? And it turned out that actually you couldn't make sense of human speech unless you just took every sentence and every word. And the conclusion at the time, and this is only 25 years ago, was that we would probably never be able to teach computers how to understand human speech. And by the way, we didn't really understand how humans did it either. So that was, in a sense, state of the art 25 years ago. Fast forward now, of course, we have computers that are incredibly good at understanding human speech. So the question is, what changed? And what changed was a massive paradigm shift in which we moved away from saying, let's just try and inductively understand if you did this, then that. And let's instead just take a whole load of big sets of what you might call input data. In that case, lots of sentences, lots of recorded speech. And then let's think about what the output might be, which might be, in the case of speech, what does this word mean? What do I say next? In the case of facial recognition, it might be, who is this person? And it turned out that if you get big enough data sets, and you have enough tagging of those, in other words, you can say this then connects to that, and you have enough fast compute power, then even though you don't really know how it works, you can start to solve hard problems like human speech or facial recognition. And by the way, facial recognition got cracked only when cameras started getting cheap enough to go on phones all around the world, and people started writing the names of their friends, their family, and their relatives all over that. And that suddenly gave you, in a very short period of time, an unbelievably well-structured, tagged data set. And off the back of that, bing, you can do facial recognition. So just a massive paradigm shift very recently. And for that to work, you need data, you need a little bit of modeling, but that hasn't really changed in 25 years. You need data, you need tagged data sets, and you need compute power. So that's the sort of general sense in which, as we think about this, you want to have a sense of what is it about data and why might it be relevant to medicine. The other thing I'll say generally about data is it's not always brilliantly understood what it is that creates value, particularly in the deployment of AI or machine learning or all of these cool terms you need. And it's often felt that the test should be, is the machine making a better decision than I, a human being, can make? And that is not the test, because that's not how the value is created. The value is created not necessarily because you make better decisions, nice if you can, but that's not where the value comes. The value becomes because you make these decisions faster, much faster, billions of times faster. And it turns out that if you can make decisions billions of times faster, you can make them at a much more granular level, and you can start to do things like personalizing decisions. And it turns out when you start to do that, that ends up becoming an incredibly powerful value creation lever. So that's just the meta thought, because it's important, again, when we think about the deployment in a medical context. It's velocity we should be talking about, and velocity matters because it means you make individual personalized decisions as opposed to broad brush generalized decisions. And a lot of the time, that makes you better decisions in totality, even if each individual decision may be no better. So that's data. What does that mean in terms of data and health? I think if you think about health, and this is not specific to the UK, this is a global issue, data, in some reasons, when Nilesh mentioned, he and I have been working on this question of data and health in the context of cardiovascular for 5-6 years now, actually in some ways, remarkably little has been done. These are extraordinary new paradigms, new technologies. They've been deployed in all sorts of mundane areas like shopping and dating and, communication. Remarkably little has been done in health. And yet, if you think about the only way we're going to be able to sustain our healthcare system going forward, it's going to have to make a number of changes. It's going to have to move from fundamentally late-stage reactive to early-stage predictive. We all know that whether you're talking about cardiovascular or diabetes or cancer, the earlier you identify, the earlier you can intervene, the better the prognosis. And that question of lots of large-scale data, whether it's coming from continuous monitoring of blood pressure or genetic analysis or even just your Fitbit, that's a lot of data. We know what the outcomes are, likelihood to develop ATF or whatever, or any of these other diseases we're worried about. That just looks awfully like a standard big data problem. And so it shouldn't be, in principle, that hard to deploy it. And if we can do that effectively, you get a paradigm shift in medicine, which is you identify much earlier what might be going wrong, you're capable of intervening much earlier, you have much better prognosis. And that's a radical shift that moves you from late stage reactive to earlier stage predictive and much more intervention with better outcomes. It also, in principle, means the future of data should be about a much greater level of personalization of the approach. Think about even the most basic things. You go and get a prescription, it's 6 pills or 12 pills. Well, is that right for the individual? Is it always that you should take, a course of even something as basic as antibiotics for 5 days or 7 days and 3 times a day in these doses? What if you could personalize the approach? What if you could actually, over time, learn how a specific intervention at a specific moment, at a specific individual is? Hypothesis, because we've not proven it in the case of healthcare, but strong hypothesis based on all the evidence in every other domain we've looked at is that would probably produce much more powerful and better outcomes. And then finally, and we all understand this, if we think about a lot of the disease classes, there's a huge piece which is about individual behavior, whether it's diet or lifestyle or interventions you can make, all that wonderful stuff we heard from Kelvin about, how do you feel bold enough to be able to fly upside down in a Spitfire because, you've looked after yourself, you've made your own personal interventions. That's another thing which needs to be a huge part of the future of healthcare, almost a self-serve, self-help. How do we do these things? But you're highly unlikely to be able to do that unless you can actually almost have a continuous, ongoing, always-on relationship with the individual in which they know enough to be able to know, what should I do next? What is the next best action? What is the next best intervention? So there's probably a future of healthcare out there, which is something about data can enable you to intervene much more early and much more effectively in a much more targeted way. There's probably going to be something around personalization of interventions and approaches. Now, we do that to some extent, of course, whenever an individual physician meets an individual patient, but maybe we could do that across every intervention you make. And there's probably something about a continuous, always-on, empowering individuals to know enough to know what actions they themselves can take to help. So that's just some interesting thoughts about where health is going generally. Let me talk a little bit about cardiovascular. It's obviously a subject very close to all of our hearts, excuse the pun, as we talk about this today. And in some ways, Nilesh and I and all of us at the BHF spend a bit of time looking at cardiovascular and looking in particular at what has the impact of the nearly 60 years, over 60 years now, of funding of research in this area been. And in some ways, it's been extraordinary. If you look at the long-term trend, there's been a 70% reduction in age-adjusted mortality rates from cardiovascular, 70%. That is completely unprecedented in any other disease. There's no other disease class in the world that's achieved that kind of progress. It's extraordinary. But, and there's a big but, and that, by the way, has come from successive waves of investment in research, of coming up with new interventions, whether it's drugs or just how do we make surgery safer or what else we can do. So research has driven an extraordinary improvement in age-adjusted mortality rates of cardiovascular. But, and this was the conversation that we all had, I guess, 5 or 6 years ago, the but is that improvement rate has been slowing. And in fact, just over the last year or so, for the first time, the curve started to go the wrong way. And that's partly because some of the interventions, most of the last 20, 25 years has about been drug development and just reaching a point of diminishing returns. It's also, of course, about the fact that we have lots of demographics coming against us, mobility, obesity, aging populations, multimorbidities. So the curve is going the wrong way. And so that was really what inspired us to say at the BHF, just carrying on doing what we're doing is probably not enough. We need to actually find the next big thing or the next big things that's going to give you that next wave of innovation that will transform cardiovascular care for the next 10, 15, 20 years. And so we decided to place a number of big bets. As Nilesh knows very well, we're fascinated by the concept of regenerative medicine. We're, of course, we've been running this program called the Big Beat Challenge, which is about really trying to come up with genuinely breakthrough ideas. But it seemed inconceivable to us that one of those big bets shouldn't be around medicine and data. Hence the support for the BHF Data Science Centre and bringing Cathie and the fantastic team along. Hence a lot of work, as you heard, around how do we get the patient consent and reassure. Hence a lot of work around the science, our partnership with the Turing Institute, and actually hence trying to now actually put it in practice. Hence the Cardiovascular Catalyst Fund, which is a fund we launched a little while ago that's actually just coming up to look at ideas for trying to deploy data science in clinical settings, frontline clinical to practical deployment that can make a difference. So it matters in cardiovascular. Let me just touch on one final point before we open it up, which was what did we learn during the pandemic? Because I think we learned a couple of interesting things. I think we learned, and I'm sure you'll hear more about great examples during the day. I think we learned, and by we, I mean the medical community generally here in this country and globally, we learned about the power of large data sets. We learned how important it is that we have, the Data Science Centre, we have HDR UK, we have Biobank, because it's only those data sets that enabled us to really understand the science of what's going on, to be able to identify, for example, the small but risk of cardiovascular disease from vaccines and things like this. So we really learned that those data sets are critical to actually really being able to inform policy and interventions. I think we also, amazingly, as you know, under the COVID emergency regulations, a lot of those historically impossible to break down barriers around the sharing of data, and you heard a little bit about this from Kelvin, those were broken down. So, the rules expire in July this year, but actually that linkage of primary to secondary data has been done. And we know how incredibly powerful that is. And you know what? Okay, it was an emergency, it was a global pandemic, but we haven't seen an extraordinary massive backlash against it because I think we've been able to truly demonstrate the value of this. So compared to where the debate perhaps was 2 years ago, I think there is a one-time opportunity to really properly articulate that debate. How do we balance the genuine, legitimate concerns around privacy and who has the data with the clear, demonstrable value to research and to public health generally? And then finally, and this links to me a little bit back to that point about how do we actually, how do we get to a bit of patient self-help here? We have this thing now called the NHS app, which astonishingly is now currently actively used by 27 million UK adults. It's more than half the population, more than half the adult population. That's astonishing. And it's got a compelling use case, which is you kind of need to get your COVID pass, otherwise you can't do anything. So we've got that usage. But actually that creates opportunities that simply didn't exist. We actually now have unique identifiers for the vast majority of the adult population in the UK because we needed to put that in place in order to roll out vaccines. So actually, we have made an unbelievable step change in the potential. We just now need to decide what to do next with it. So let me stop there and take some questions. I think what next? I think it's really important for all of us that we keep proving the value, and that's why it's so great to have a day like today and just see some of the amazing work that's been done. I actually think it's really important we don't waste the pandemic opportunity. It was such a horrible, traumatic, awful experience we've gone through that let's not waste the few things we have learned. And then perhaps most importantly, I do think we've been talking about this for a while. I think actually we're now at the point where we can really begin to make it happen and we can genuinely transform healthcare. So thank you for listening. I think, Nilesh, you've got a few questions you want to fire at me.
Great. Doug, absolutely fantastic talk, and you covered a number of key issues. There's a question already come through, which was one that I was going to ask anyway. You told us let us not lose the opportunity that the pandemic has provided in terms of data linkage. As you said, when you set off the BHF Data Science Center, if you said Cathie an objective about linking different data sets, we would have probably given us some years to achieve this. We knew how tough it was, and within a few months, the Data Science Center managed to link data for COVID-related research. The question I think this audience would appreciate, I think, that we need to take this beyond the post-COVID era in terms of maintaining those linkages. How do we do that? What are the levers that we need to try and engage to make sure that this happens? Because otherwise there's a worry that this will all go back into the silos and we don't achieve it. So your perspective on this, particularly since you sit on the Department of Health, so exactly, what's the sense here about how we do this beyond
No, totally. So I think this is a critical, as all the research community in particular, a critical and urgent issue. It's an urgent issue because everything that's been achieved and all the amazing work, Cathie, you've been able to do and the value you've demonstrated from that during the pandemic, that was done under a set of emergency regulations that expire in July this year. So there is a sort of ticking clock that says if we don't fix this issue, we'll take a massive step back. And having taken a step back, it will then be, as we all know, super painful to step forward. I'd say two things that give me a certain level of encouragement here, and then I'll come on to what I think the community and in particular the research community can really help with. One of which is this is a known issue. It's on the Secretary of State's agenda. I know that. Tim Ferriss, who, as you probably know, now has both the brief for transformation within NHS, but also now, following the recent changes, NHSD and NHSX have been brought together. They're all reporting to Tim. I know Tim is all over this, and in a sense, it's on him to solve the issue, and he's been tasked with, let's make sure we don't lose it beyond July. It's discussions we've had at Biobank with RJ Kekar and others. So I think there is a way forward. So first of all, it's there, it's been debated. It's incredibly important, though, that we all use all of our sort of connections and networks to continue to say, look, this is the value we created. This is why it matters. This is why we need to be able to keep it going. The second thing I'd say is I think the good news is it's not a technical issue. It is simply a policy issue. And actually some of the policy blockages, as we know, is that in many cases, if we just take primary healthcare data, each individual GP practice is the data controller. And therefore, as things currently stand, now that was overridden by the emergency legislation, but if we flip back, it's then down to each individual GP practice to decide whether they're willing to give the consents. They take the legal risk, they're the ones, and we all know what the likely outcome of that will be. We've seen it, for example, in the Hackney situation where, if we allow that situation to continue, it's very unlikely that we'll get high levels of opt-in, and it's impossible that we'll get complete levels of opt-in. So that's not going to be a great situation. So I think actually there is a path through this, which is about saying just move the ownership, take it away from it being the responsibility of the individual GP, probably vest it in the NHS centrally, so that they can actually then take a policy decision and make a single decision nationally or across the all 4 nations. Some of these are devolved issues, but hopefully across all 4 nations of the UK, so that we can actually say we can properly balance who gets access. Clearly, purpose of research, anonymized, much less risky than, if the other extreme, nobody's going to want to rush out and give it away, de-anonymized for commercial gain, etc. So there need to be those rules. But those rules and that framework should be established once naturally as a policy with debate. And I think we're in a much better place than we would be to have that debate 2 years ago, because you can prove the value. So I think that's where it's going to go. But it's a super live issue right now. And I think what all of us here, particularly in the research community, to do is continue to bring forward those use cases, continue to feed it in, continue to just make a bit of noise about, wasn't it amazing that we could do this stuff during the pandemic? Because I think that would just help. And ultimately, remember, these things they have to be the decisions for politicians. And politicians will obviously, to some extent, want to understand that they're not going to take a massive risk with a backlash. And that in turn, the public, the patient view is going to be influenced by hearing some of the things like the wonderful case story we heard earlier today.
Thanks, Doug. I'm encouraged by the fact that this is a live issue in the department, and you mentioned Tim Ferris overseeing this. I think just really bring the other members of the panel up, but maybe just turn to Kelvin as well to just ask the question. Ultimately, things get changed if the public mobilize behind these sort of things. I mean, it's all right for research, it's all right for Cathie as a conflicted director of the Data Science Center, or me or Andrew saying we need this. But what we really need is a public movement which says that this is safe and this is needed. Because I think you're right that there's a very GPs consider themselves to be the data custodians. They feel they're acting in the interest of the patients, and they hold that view. But I wonder whether the public has a different view of this, and this mobilization of moving the control to the center requires public consent, or at least assessment that there is a public consent to this, because otherwise there will be a barrier. I wonder how we can mobilize that as a research community to get the public to talk about this. Do you have a view on that, or maybe Kelvin can come in as well?
Oh, I'd love to hear Kelvin's perspective, but I would say, and one of the things I've always loved about the BHF is the really active use of patient panels. Because as you know, as many people on this call know, this is about reassuring that we're not going to do anything terrible. It's about demonstrating that, of course, let's be very candid about it. Of course, there's going to be a question: if I'm going to allow my information to be shared, does that potentially cause all sorts of potential harms? There is, we can't say that's zero risk. It isn't. So what we have to be able to do is demonstrate that it's of massive benefit. And I think that massive benefit, at one level, it's always a head-heart thing. There's a little bit about let's bring the data, let's demonstrate, let's show the sort of improvements in health outcomes or the specific interventions. But that heart piece is really around the individual patient stories. The fact, and we heard that wonderful from Kelvin early, actually it made your life better, it made your life easier, it allowed you to do something you wouldn't have otherwise been able to do. I think the more of these stories we bring out, the authentic, genuine patient benefit of this, I think that will, over time, I do passionately believe, sway opinion. And there is also then the other thing we can do is, again, Biobank's a good example here, where you've got a database, extraordinary resource of absolutely fully consented people sharing genetic data, sharing sort of longitudinal data. For a lot of the applications we're talking about here, that doesn't need to be linked back to the individual patient. That can be properly anonymized data. You can get huge research value without necessarily needing to know it is this individual. There will be certain applications where actually genuinely for it to be a benefit to me, we do need to know who you are. But it does slightly come back to that. I think we need the stories. I also think we need to be able to increasingly, and that's why I focus on the app, because it's out there at a massive level. Right now, you've got this fantastic, use case, which is I've got the app, I'm going to keep it on my phone because I need to be able to get my QR code. When that disappears, there's a kind of a what's next. And if that what's next was genuine patient value to me individually, if it was leveraging some of the amazing sort of advice and guidance we put in, then I think people will keep the app. And I think if people keep the app, then you can build value around it and you can gradually reassure. So I think I'm a huge believer in the stories, but yeah, stories, patient, and genuinely, ultimately each patient will make a decision. Do I feel comfortable that I'm getting enough value out of this to be willing to share my data? Which, by the way, is exactly the same conversation you get with any other organization that thinks about trying to collect data. And back in my commercial days, most people are saying, yeah, I'm totally fine. I share this data, you improve my experience, you give me better recommendations, better advice. That's a trade-off I'm very comfortable with. I think we need to establish that same trade-off in the health setting.
Okay, great. Thank you, Doug. Colleagues, Cathie, Kelvin, did any of you want to come in on this issue, which is going to be a burning issue for us over the next few months? I just wanted to, and so two meaty issues we dealt with. One is about public trust, and the other is about what happens post-COVID.
I think great to give Kelvin the last word.
Yeah.
Thank you. It's amazing. I said in my presentation that people that have experienced a chronic illness are very open to allowing their data to be used. But those who haven't even thought about it very much. I'm just hoping that with COVID, people will have realized just the importance of that data, that personal data. And so somehow or the other.
Oops. Came in at an important moment, I think.
Yeah, we seem to have lost Kelvin. Sorry for that. I think you were going to suggest Andrew just provided a few comments, Nilesh.
Yeah, Andrew?
Yeah, and thanks, Doug. Thanks, Kelvin. Wonderful talks. But I think this issue of demonstrating trustworthiness is really at the heart of the future of health data science for public benefit. We should recall that care.data was entirely legal. It lost the social contract. So being really explicit around the risks and the benefits of data sharing at scale are going to be very important, and co-developing that with the publics. And I think that's where the BHF, and we've with HDR UK have tried to learn from the BHF and other medical charities about how to involve the publics every step of the way. I think it's a policy issue. I think the concern, well, the evidence is the concern is sharing beyond health. In the recent past, there's been issues around sharing with the Home Office and other such government bodies. So I think really clear around access and trustworthiness of access is going to be very important if we're to maintain the social contract, which we have won during COVID. So I think this is going to be a key issue.
Super. Thank you very much, Andrew. And thank you to Doug. Thank you to all our speakers from the first session. Apologies to attendees who are having any problem with the visibility. We'll have that sorted by after coffee time. So do go off, enjoy a coffee. Come and join us again at 11:15 for the next exciting segment and session of the day. And we'll see you all again soon.